All right, so welcome to the Bottom Up series on the knee. My name is Gabe Dorn, and I will be presenting today. Um, Bottom Up series is a series that we initially did as a collaboration between Golden Endurance and BP Run Co. So kind of shout out to BP Run Co. We went there in person once a month and did a strengthening series where we started from the foot and ankle and worked our way up. And so we're doing something similar here, but this is a virtual webinar series. But just wanted to give BP a shout out because we originally did this series out of their running store in the Crown Hill area. So again, this is the Bottom Up series on the knee. My name is Gabe Dorn, and I'm presenting as an owner of Golden Endurance. So at Golden Endurance, it's me, Sammy Lewis and Mark Marzan, who own Golden Endurance. Sammy and I are physical therapists who coach. We're also coaches who do PT. That's kind of our background and motto. Mark is not a physical therapist, but he's a great coach and very experienced in the ultra endurance realm, especially with 100 milers. And so we are based out of Golden, Colorado. We offer strength training, physical therapy, and run coaching services. And if you look in the corner down here, and if you've been in our clinic, we've got a little clinic dog named Penny, who's a Bernese Mountain Dog and likes to hang out. So that's a little bit about us at Golden Endurance. Today we're going to go over the knee. Topics of the knee include anatomy, kinesiology, knee function for runners, common conditions of the knee, mobility exercises, and strengthening exercises. And so at any time, feel free to interrupt me. It's hard for me to check the chat, so go ahead and unmute your mic and just make questions, kind of just interrupt me and ask any questions you might need. And I'll try to answer them. So in terms of the knee, we're just going to start with some basic anatomy. And looking at the front of the knee, you basically got three bones, or really four bones that make up the knee joints. There's the femur, the tibia on the bottom, so the femur coming from your hip, the tibia on the bottom, and the kneecap or the patella. And then there's also the fibula, which the joint for that is a little bit removed from the knee itself. But basically, you got four bones, and then you've got two joints, or two or three joints, depending on if you count the fibula. So one of the joints, the main joint, is where the femur meets the tibia, and that's the tibial-femoral joint. And then you've also got the patellofemoral joint, where the kneecap, the patella, interfaces with the femur. And so with patellofemoral syndrome is a syndrome we're going to talk about where people have pain in the front of their knee. And that's really happening at the level of the patellofemoral joint. So where the patella interfaces with the femur, we've got, that's a source of pain for some people. And then we've got, so you got the patellofemoral joint, the tibial-femoral joint. We've also got the tib-fib, the proximal tib-fib joint, which again is kind of outside the knee capsule, but close enough to the knee in proximity that we can talk about it as a joint of the knee. So that's the front of the knee. If you layer in muscles over that, that's kind of what it looks like, where you've got the quadriceps coming down to form, or quadriceps coming into the kneecap, into the patella, that form the patellar tendon. And then you've kind of got muscles wrapping around both the inside and outside of the knee itself, but it's mainly the quadricep muscle group that's the big movers through the front of the knee. Through the back of the knee, this is what it looks like without the muscles, where you can kind of see the ligaments a little bit better, including the PCL right here. That's that V. And then the ACL, you can see a little bit of that as it comes through, attaches along the back and goes to the front. And then you've got both meniscus. And so the meniscus kind of sit between the tibial-femoral joint and provide cushion. And you got a meniscus on the inside, the medial meniscus, and a meniscus on the outside, the lateral meniscus. And then you've got some other ligaments that stabilize the knee side to side. But that's kind of the back of the knee. If you layer on muscles on top of that, you can see you've got the hamstring group up here and the gastrocsoleus that actually crosses the knee joint. So before we get into kinesiology, I'm just going to pull up kind of what that looks like from a 3D perspective. So we're looking at this image here, and oh, too much zoom. So this is the front of the knee, where you got the kneecap, and then this is the quad tendon that attaches to the top of the kneecap, and that goes in and forms the quadricep muscle group. So this is the quadricep muscle group through the front of the knee, and you can see there are 4 different muscles, 3 that you can see, and then if you were to dissect this one, there's one underneath as well. And then, so you got the quad going into the knee joint. It forms the patellar tendon or quad ligament, and that can be a source of irritation, although not super common in runners. That can also be a source of irritation. So that's kind of the front of the knee from a 3D perspective. And then when we look at the side, this is looking at the left knee. So like looking at it from this angle, where you got the foot down here. So this is left leg, and looking at it from the outside, you got the IT band, and so that's this big band that comes down, crosses the knee joint here, and then goes up and attaches to the TFL and the glute max. And so when we talk about the IT band, we have pain down here at the outside of the knee, but really the muscles that contract and make the IT band dynamic are higher up at your hip. And so when you talk about treatment for the IT band, we're really talking about treatment of the hip as well as the vastus lateralis that interfaces, that's a quad muscle that interfaces with the IT band from the more the front. And then we go to the back of the knee, and you got primarily, so this is that limb, and we're zooming into the knee. You've got the hamstring group, which this is the biceps femoris, and then we've got the semitendinosus and semimembranosus back here somewhere. I'm not quite, should be back here. There it is. Semimembranosus kind of behind this semitendinosus. And so those 3 muscles make up the hamstring group. Semimembranosus, tendinosus, and biceps femoris make up the hamstring group, and all 3 of them cross the knee joint. The biggest one, the biceps fem, crosses the knee joint on the outside, and then these 2, semimem and semitendinosus, cross the knee joint on the inside of the knee. And then we've also got muscles that come up from the shin and cross the knee joint, primarily the gastroc muscles, right? So you got the medial letogastroc and medial gastroc. And then we look from the inside of the knee, and we've got, so here's the knee joint. If we zoom out, we got the adductors. And these muscles kind of pull the leg in because their angle pulls from the inside. So they attach to the pelvis, and then they pull the leg in this direction. So they adduct the leg, muscles on the outside of the hip and outside of the knee, kind of abduct the knee, whereas the muscles along the back extend the hip and also bend the knee, whereas the muscles along the front flex the hip as well as straighten the knee. And so that's kind of the basic anatomy of the knee joint. And like I said before, stop me if you have any questions. I'm not able to check the chat because I'm in full screen mode. So just go ahead and stop if you have any questions. But that's kind of the basic anatomy of the knee itself. All right, so kinesiology, or movement of the knee. And when we're talking about movement of the knee and what we look at in physical therapy, we're really talking about movement through the stance phase of gait. And so that's where the leg is on the ground. We're not really concerned with like the float stages or swing phases where the leg is moving through the air, because there are no forces going through the knee when the knee is just moving through the air. It's more when you're landing, like when you have some kind of initial contact, you go to mid stance and you go to terminal contact or toe off, is when you get forces going through the leg. And so we're really concerned with the stance phase. What is that leg doing on the ground? How is it absorbing forces from the ground? You know, when you land on your foot, there's a ground reaction force coming up into the ankle, knee, hip, and low back. And it's how you mitigate those forces. What muscles do you use? How do you land? That determines where you put the stresses through the different joints. And is it more through the front of the knee, the back of the knee? So we're really concerned with the stance phase when we're talking about rehab of the knee. And so just to break that down a little bit, when somebody is landing, we're looking at this angle right through here relative to their hip. We're drawing a line from their hip through their knee and then taking an angle to their shin from there. And it's this angle, the amount of knee bend that you get during gait that we're looking at. And so when you first hit the ground, we're really looking for around 28 degrees of knee bend. And so that would be this, this angle here, 20 degrees of knee bend. And then as you move through gait, you start to absorb some of those forces and you bend through your knee more till you get to mid stance. And mid stance, you're really at 40 to 45%, degrees knee bend. And then your terminal stance. Terminal stance, we're not as concerned about because there's less forces compared to like a braking force. When you initially land, there are less forces at terminal stance, and so we're not super concerned about that. But that's just a little bit of knee bend through terminal stance. And so we're looking at this through video analysis at the gait cycle. And if somebody has like a ton of knee bend at initial contact, that might mean that they're putting too much stress through their knee, or they're really good at using their quad. Whereas if somebody has a really rigid knee, that they may be guarding through their knee and not appropriately trying to absorb that force through their quad. And so those are things that we're looking at with gait. And what that looks like dynamically is that we get someone on a treadmill and take a video of somebody on a treadmill where we're taking it, they're running at their normal distance day running pace. And then we're breaking that down and getting them in slow motion, basically, and looking at really initial contact, mid stance, and terminal stance. And not just that, but actually kind of finding a spot where we're going to take like an angle from here. And so I'm kind of finding when they first hit the ground, their initial contact, drawing a line from their hip through their knee, and then taking an angle from their shin through that imaginary line. And not an exact science, but you can see I'm roughly landing at about 24 degrees of knee bend at initial contact. So that's like a relatively appropriate amount of knee bend. And I do the same thing for mid stance, where and that's it'll show you that in a minute, but I'm basically finding mid stance, which there's different ways to find it, but we have a specific method that we use. And then it's the same thing where you're taking an angle, looking at that angle, and finding, is that an appropriate amount of knee bend? And for me, it's right around like 44 degrees. And so that's kind of within the 40 to 45 degrees of knee bend that we're looking for with gait. All right. Any questions on anatomy, kinesiology so far? Because that kind of covers the basics of like the anatomy and then how we move, what we look for in video analysis as therapists. Now we're going to get into a couple of syndromes and look at describing those syndromes, and then look at what that might look like on the treadmill when we're doing a video analysis for somebody. And so patellofemoral syndrome, also diagnosed as anterior knee pain, is a very generic term where it's a syndrome. It's a cluster of signs and symptoms. It's not super well defined and it's pretty generalized in that it basically just means pain in the front of your knee. It was previously thought to be an issue of patellar tracking, where the kneecap was kind of tracking wrong in the femur. That's a little bit of a dated term. Now we just use patellofemoral syndrome to describe knee pain that kind of moves around the front of the knee. And it's not super specific. It's not like joint line pain where it's like, oh, this is my meniscus and it hurts like right in the joint line. This is more diffuse, like, oh, it'll hurt over on the inside of the knee and then it'll hurt on the outside of the knee. And it's not super specific to any one point of the knee. So it's pain that moves around. It's usually not super sharp. It's more dull and achy, and it might be pain that warms up a little bit. It occurs with sudden increase in miles and a sudden increase in intensity. And so we see this a lot with beginner runners or people who have inappropriately ramped their miles. And so if you're going from like a couch to 5K, if that couch to 5K was too aggressive too soon, you'll see pain in the front of the knee just because the load is too much. They might be running fine. There might be nothing wrong with their gait. It may be just that they went too quickly into higher mileage. And so you see that a lot with sudden increase in miles, sudden increase in intensity. You also see that with individuals who overstride, and that's more like something that we're looking at on the treadmill, and we'll look at that in a second, what that looks like. You see it in running in like old shoes or running with a super high heel drop, because if you're getting your heel up, that means you're bending through your knee more. That means there's more force going through your knee. And so you'll see it with shoes that have a drop of greater than 8 millimeters with runners. So the treatment is really looking at load management. Like, what can we do to mitigate the volume? Like, whether you're programming in terms of miles or programming in terms of just time. And then looking at intensity. Are you running too fast? Is your pace too fast? Are you running too fast too frequently? You don't have any off days. You're doing too many workouts in a week, or all of your distance runs are at like an 8 or a 9 out of 10 when they should really be like at a 5 or a 6 out of 10. So looking at load management is really important, and we've got a whole webinar series on overtraining, and the first of that series, just overtraining and the endurance athlete, really takes a deeper dive into load management and what you can be doing from a load perspective to mitigate injuries. So that's a great series if you want to learn more about load management. Correcting overstriding by increasing cadence. And so we'll look at what overstriding looks like on the treadmill in a minute. But you're basically, if you're reaching out in front of you with your leg, all of that ground reaction force is going up through your heel, through your knee, and potentially into your hip and your lower back. And so your knee is just taking a lot of force if you're reaching out in front of you while you're running. And we'll take a look at what that looks like in a minute. And so we want to correct that, but also work on strengthening the quads, hips, calves, and core. So all the surrounding muscles and even up the kinetic chain into the hips and pelvis and core to work on mitigating that stress through the knees, so that you're not just taking it through the knee itself, but you're taking it through the quads and the glutes and the core. And then in PT, we'll also do things like dry needling, massage, foam rolling, lacrosse. Like we'll dry needle the quadriceps muscle group. We'll dry needle the glutes and the calf and the hamstring. We'll do all of that to kind of calm everything down. It's a good way to reset the system. It's not curative, meaning that you still need to work on correcting gait things that may be causing pain, like overstriding. You also definitely need to be working on strengthening it. So like people come in and they just want to be needled. That's fine to help with the symptoms and the pain you're having in the moment, but that's not helping with load over time. And so to really focus on load over time, you want to work on strengthening and also work on incrementally loading over time. And so that's like a lot of times with patellofemoral syndrome, that's a training volume issue, right? Or training intensity issue. So it's basically a training error where you're doing too much too soon. And so you want to look at that as well as strengthening the quads, hips, calves, and core. So what does overstriding look like that might lead to patellofemoral syndrome? So this is the same video. And I mentioned that I overstride before. I'm just finding that initial contact where my heel or foot is hitting the ground. And then I'm going to draw a line through midline of the body. And you can see I'm quite a ways in front of that midline. So I'm really reaching out in front of my body. And that's what overstriding is there. And you can see that if you hit the ground, you're exerting a force into the treadmill, into the ground. And then the ground is exerting that force back on you. That's like principles of physics, right? And so that's the ground reaction force hitting the ground. Ground reaction force comes down, and then the ground exerts a force back through your body, and that goes through your ankle, your heel, into your knee. And your knee is really the first joint. If you're heel striking, your ankle's not taking a lot of that force. It's really your knee that's taking the majority of that force if you're overstriding and heel striking. So heel striking, not necessarily bad. It does put more force through the knee and the hip. So if someone's got foot pain, heel striking might be desired because you're taking some of that stress off of the foot. It's really where you're heel striking. If you're heel striking right under your body with the midline of your body, then that's significantly less force than if you're heel striking out in front and you have a braking force, basically where you hit the ground out in front and then the ground is exerting a braking force back at you. And that's really what we want to try to avoid, because all that braking force is kind of going into your knee and hip joints if you're heel striking out in front of you. If you're heel striking underneath you, not as big of a deal because that is almost propelling you forward. But if you're heel striking out in front, bigger deal, more braking force. So that's overstriding in a nutshell. Super common with new runners and super common with patellofemoral syndrome. So that kind of goes hand in hand. All right. So the next thing we're going to talk about is IT band syndrome. And a lot of people have probably heard about IT band syndrome and rolling the IT band or the surrounding muscles. And so this is basically where you get a sharp pain on the outside of your knee, where this is the IT band, this long white band, where the long white band crosses the knee joint. You get a sharp pain. There are lots of structures that could cause this sharp pain. It's mostly caused through friction, where the IT band is kind of rolling over the femoral condyle. So the bony part of the femoral condyle is basically compressing the nerves and the bursa in that spot. But you can also get friction at the knee joint itself. But yeah, it's classically described as like the IT band rolling over the femoral condyle, causing friction and compression at the nerve endings. And so this is definitely a sharp pain on the outside of the knee. And people notice it with, again, a sudden increase in miles or intensity. So basically a training error. Definitely with downhill running, your leg is taking more force, but it's also putting that IT band in a place where it could easily compress nerve endings and cause very sharp pain very quickly. You see this with sometimes overstriding, and then a lot of times you see this in triathletes because they're just higher rates of IT band syndrome in cyclists who also run. And so you see that in that population as well. In terms of treatment, you really want to work up the chain in terms of glute recruitment, strengthening, and really loading the knee. Because you think about downhill running, you're basically hitting the ground, bending through the knee into like a single leg squat position. And that's putting a lot of load directly through the knee. So you want to work on having your knee better be able to accommodate that load. And then you're working on glute recruitment and strengthening, primarily because of how the IT band interfaces with the glutes. And so if we go back to the diagram here, this is the front of the leg. This is the IT band right here, highlighted in yellow. And you can see it crosses the knee joint, and it's that friction that can cause some of the pain and symptoms. So it crosses the knee joint, and then up at the top part where the IT band attaches on the top, it interfaces with the TFL, the tensor fascia latae, as well as the gluteus maximus. And so it's really important. These muscles can get knotted, they can get dysfunctional and not used, where the IT band takes more of that force, and where the IT band just naturally becomes stiffer and more angry over time because you're not taking any of that force through the glutes, specifically the glute max. And so working on mobility and rolling through the glute max, as well as working on muscle recruitment and actually strengthening it and getting it firing over time, is really important in treating symptoms at the knee. Sometimes I'll stick a needle up here and you'll also get referred pain into the knee. And so sometimes it's not even the band itself. Sometimes it's referred pain from the hip that can be missed commonly in exams. But yeah, that's basically trying to get recruitment up here, as well as loading the knee itself, loading the quads through things like step downs and lateral step downs and slant board squats, where you're basically squatting on a decline. But we'll get into more exercises specifically later on. And so that's another really common syndrome. We're working on treatment through glute recruitment, strengthening, eccentric loading. We talked about that. Addressing any abnormalities in terms of their gait. Overstriding is one. We're also going to look at what hip drop looks like in a minute here. Working on core stability, strengthening, and then ancillary hip mobilization, IT band mobilization, foam rolling, stretching. So a lot of people are like, oh, I got IT band syndrome. I need to roll my IT band. And the IT band is a really big, thick band that doesn't change in length. Like, there's no way you can roll it to make it looser. Like, a lot of people will roll it and they'll feel better. And that's sometimes a neuromuscular effect where they think they're rolling the IT band, but they're actually rolling, didn't mean to do that. They're actually rolling the muscles surrounding the IT band, so they're rolling the vastus lateralis. And you can definitely, the vastus lateralis is another muscle that interfaces with the IT band, so you can definitely get relief by rolling the vastus lateralis. But you're not making any changes in terms of the length of this or the stiffness of this band. It's freaking solid. Like in human cadaver, when you dissect this band doesn't move. It's really hard to cut through. It's really hard to break up. The thought that you're going to take a foam roller and do anything to increase the elasticity of this band is kind of nonsense. What you would do is roll the surrounding muscles like the vastus lateralis, the biceps femoris, which is another syndrome, the biceps femoris friction syndrome, basically, that can mask as IT band syndrome. But you're really not, you're not doing anything to change the length of this. You can still roll it if it feels good. Just know that you're better off working on glute recruitment up higher up and working on strengthening over time and loading over time. That's your biggest bang for your buck in terms of treating the IT band. Okay, so hip drop. So we talked about glute recruitment. This is what happens when glutes are not recruited. You can see on my left leg as my stance leg, I drop through my right hip. So I'm on my left leg, drop through my right hip. So now I'm going to break that down. Where I'm coming onto my left leg here. I'm going to draw a line at my waist, and you can kind of see my waistline is even in this position. So I'm drawing a line to reflect that evenness. And then as I load my left leg, I drop through my right hip. And so this is a weakness of the left glute, where you can see, if we were to angle that, you get an angle dropping down where you're no longer level at your hips. And this puts a lot of torsional force through your knee. So just to break that down a little bit more, you're even, and then you put more of your weight on your left leg and your hips drop. So there's no core pelvic stability here. It's all going through the knee, and that force is kind of coming down in this direction. And that puts a lot of torsional force through the knee and can commonly contribute to things like IT band friction syndrome. So that's what a hip drop is. And you can see I'm really accentuating it. I'm just exaggerating what it looks like here. But if I were to see a hip drop that big, that consistently, I would say, okay, we got to treat that in the clinic. We got to start working on glute recruitment to turn those glutes and muscles of the hip back on so that we can take some of the stress off of the knee. All right. So we're just going to go through some mobility exercises. Feel free to jump in and ask questions. I'm going to give you some time to actually do them. So if you have a foam roller, go ahead and grab it now, and you might as well grab a looped band, because we'll also go over some banded exercises as well. All right, so in terms of rolling through the quads, flip this, there we go. So Sammy is just demonstrating how you would foam roll the quads. This is more to just get things moving. So you're foam rolling the quadriceps femoris, the quad group, and you're kind of moving back and forth on the foam roller. You can do this with both legs on the foam roller. You can do it with one leg on the foam roller, but you're really finding a spot that's a little bit sore and tender, not over the knee, like more between the hip and the knee, the thigh, finding a spot and just mobilizing back and forth. So you're tacking that muscle down where it's sore and then flossing that muscle back and forth. So go ahead and try that now if you got a foam roller with you. Just doing it for like a minute at a time would be good. Starting with 1 minute at a time, doing 2 to 3 sets at 1 minute, and then eventually getting up to holding that position for 2 minutes where you're really tacking that muscle down, then bending your knee, flossing your knee back and forth. Now, if we go further with this, we're also going to loop this video where Sammy's basically taking the foam roller and working through her adductors, the muscles on the inside. This commonly presents, stiff adductors can present as patellofemoral pain, particularly if the pain is on the inside of the knee primarily. So you're kind of working from the hip or the knee, hip down or knee up, where you're kind of working from one end and going to the other, finding those stiff spots and moving it back and forth. And you can kind of see Sammy's kind of moving up her leg closer towards her hip as she moves through her knee, because that's where the muscle, the bulk of the muscle is closer towards the hip. So go ahead and give that one a try as well. So the tibial car is basically a controlled arc of motion where you're going to lock out that knee by bringing your knee to your chest, holding right behind the thigh, pointing your foot up so that you're locking out the ankle, and then trying to move your foot side to side, which is going to try to rotate the knee side to side. And the knee doesn't have a lot of rotation, but it should have some. Specifically, there's a mechanism basically called in layman's term, the screw home mechanism. When you extend your knee, the knee rotates a little bit. And a lot of people lose that mechanism when they have knee pain. And so keeping that leg relatively straight, locking out the foot, and then bringing your foot in, bringing it out, and just going back and forth to get motion in the horizontal plane through that knee joint. Go ahead and give that a try now. So these are all mobility exercises. They're meant to help with the pain. They're not going to make you stronger, right? Foam rolling your quad or your adductors or moving your knee side to side, not necessarily going to make you stronger. And so this is more if you are in a lot of pain, these are good exercises to start with, but they're not necessarily curative. And so these next set of exercises, we're actually going to work on strengthening, and we're going to start strengthening at the hip and really to address any kind of abnormalities with gait. You know, if somebody is demonstrating a hip drop where we put them on the treadmill and we see a large drop in their hip motion, then we would give them some hip strengthening exercises. And we know from research that any kind of patellofemoral strain or any type of patellofemoral syndrome, we really want to work on both strengthening of the knee muscles like the quadriceps, as well as the hip muscles like the glutes. And so the research says you strengthen both, you get better results than strengthening one independently. And so really working on some hip strengthening is going to be a good place to start. And we'll start with banded rotation, where Sammy's got the band around her knees. You can follow along at home if you want, where she's kind of getting into a mini squat or an athletic stance position. And then she's rotating her knee kind of in that horizontal plane, rotating it in. And then when she comes out, she's pushing from her hip. She's squeezing her glutes to get that outward rotation of the knee joint. And so that's kind of a prime example of if you saw somebody running on the treadmill and they had a big hip drop and their knee also fell in, that's like a prime example of someone who's not using their glutes when they're running. So doing this exercise, preferably before you go out and run, would be a way to prime the muscles of your glutes, kind of get them moving, turn them on, and hopefully get better cueing and control of the muscles themselves. So go ahead and give that one a try. We'll kind of move on to toe taps. And so this is also an exercise for your glute because you're moving through your hip as you do this, where you're standing on one leg and doing 45-degree angle backwards toe taps, and you'll feel a nice burn in your glute, but you also feel it in your stance leg hip. You can see Sammy saying, don't let your knee come in on your stance leg. We're really focused on the stance leg because that's what we see in gait, is that, we're concerned about the forces going through the stance leg, not so much the forces going through the swinging leg. And so this is just a prime example of that, where we're working on toe taps back and forth, getting recruitment of this, the right-sided glute muscle, but also getting recruitment of the stance leg glute. And if you do these for 20 or 30 seconds consistently, you'll feel a nice burn in the stance leg glute, and you want to make sure your knee's not diving in like what she's demonstrating here. All right, you can bring that band back up to your knees. And from here, we're going to do tempo squats. And you can do these without a band. The band just helps with the glute recruitment specifically. So what Sammy's doing is she's sitting down into a squat position and pushing her knees out into the band as she's going down. And then she's coming back up. And she's going to go down on a 5-second count. Hold for 3 seconds at the bottom. And then back up. So that's why it's titled 5-3-1 tempo squats, where you're going down on 5-second count. Really nice, slow, and controlled. It's a pretty fast 5 seconds from Sammy. And then she's holding for 3 seconds at the bottom and then coming up on 1. So go ahead and give that one a try. And you'll feel that in your knee. You feel it in your quad. You should feel a little bit of recruitment in your glute as well. All right, the last hip centric exercise we're doing is a lateral lunge to a march, right? And so this is great. When you're lunging into it, you're really working the stance leg glute on the right, and then as she's springing up, she's engaging more of her stance leg glute on the left. So really good exercise to hit both at once. You can definitely do it on both sides because there's slightly different recruitment patterns when you do it on your right versus your left, but this is a lateral motion, and so you're getting the hips involved laterally, which is what we want if we're trying to address something like a hip drop on the treadmill. You notice she goes pretty deep. She could go deeper if you got that range of motion. If it hurts to go deeper, if it hurts to bend through your knee a lot, you definitely start doing this more, not going shallow and not going as deep, and then working on the balance coming up and the control. You can see that first one, she's kind of wobbling all over the place. So that's something that I would cue her in the clinic, but I don't give her a lot of cues because she's my wife. All right, so that's strength and control from the hip. Now we want to work on directly loading the knee. And so we're going to do exercises that directly bias the quad, that directly put a lot of stress through the knee. And you wouldn't necessarily start with these, so don't do these if you have a lot of knee pain already. But these are things that you might work into over time. And so the first one would be doing a split squat where you're biasing the quads. And so a split squat where you bias the quads, you're really staying relatively upright with your shoulders. You're doing a lunge or a split squat. You're staying relatively upright and not getting over your knee, not bringing your shoulders over your knee. When you bring your shoulders over your knee, you bias the hips a lot more. But if you go straight up and down, like Sammy said, this is Sammy biasing the hips. You really want to be upright to bias the quads, which directly loads the knee. So go ahead and give that a try, and you can play around. If you do lean forward, see if you can feel it more in your hips versus if you're more upright, if you can feel it more in your quad. So this is just an isometric lunge where you're in a lunge position and then you're working on your calf muscles. I could be doing this better where you really want your butt to move up and down a little bit more so that you're actually lifting your body through your calf and not just moving your knee. So this is a poor demonstration, and we will have to redo this video at some point. But basically, you want to come up and down so that you're actually using your calf muscles to move your body up and down and not just move your knee a little bit up, because that's a lot easier as opposed to going up and down through your body. All right, sissy squats. So this is a pretty challenging exercise, but a great way to load the front of the knee if you've appropriately progressed to it. And so you might, start with regular squats, go to temple squats, go to a split squat with a hip bias, and then a split squat with a quad bias, and then a box squat or something like that, and then try doing a sissy squat. So maybe this is not one that you do today, just because it is a little bit more advanced, but know that this was something that we would progress people in the clinic to, where you're doing a squat where you're getting your knees way over your toes, and that's really loading your knees a lot, right? And then you're coming back up, and she's doing it eccentrically where she's doing the lengthening part coming down, but she's taking a break at the bottom and not trying to go back up. So she's going all the way down, trying to do that slow and controlled and really do the eccentric work. Like I said, this one will really load the knee, and so you want to be cognizant of that and not push yourself too hard or not do a ton of these, especially if you do have knee pain. But we want to incrementally load the knee over time. And you think about with running, you're putting 3 to 6 times your body weight through ground reaction force, and that ground reaction force is exerting 3 to 6 times your body weight back up at you, especially if you're overstriding. You're taking that right through your knee. So you need to be able to manage load, and a lot of load through your knee. And so we want to progressively load the knee over time. And this is a good way to load the knee quite a bit. You'll notice we're going knees over toes, which a lot of people are like, don't do that. And it's like, yeah, if you have a lot of pain, you don't want to do a ton of knees over toes work, but you do want to get there eventually, because functionally, not just with running, but functionally, you do a lot of things where your knees are going to be over your toes. And if you're not used to, if you completely try to avoid that motion, you're not going to be able to do a lot of things around the house. Or you're not going to be able to run very efficiently, right? And so we eventually want to get to the point where we are loading our knees well past our toes, and this is a good way to do it. All right, single leg squat. So now we're going from double leg to single leg, where we're doing all of our body weight through one leg as opposed to half of our body weight. And Sammy's starting relatively conservatively, where she's not going super deep. Eventually, we want to get to a pistol squat where they're going through that full range of motion, sitting all the way down so that her butt's basically at her heel, and then coming back up. But that puts a lot of force through the knees. So how we would start people is just doing like a single leg quarter squat, which is basically what Sammy's doing now, and then working on progressing that lower and lower over time so that her knee's going further over her foot, and she's putting more of that load through her knee itself. And these joints, cartilage, ligaments, they're somewhat like muscle in that they can be conditioned to load over time. Similar to strength training, where you load the quad over time to develop a stronger quad. You can develop resiliency. It's not necessarily strength, but you can develop resiliency in your knee to make it more resilient over time. And this is a good way to start doing that. All right. So that kind of concludes our webinar on the knee. If you've heard, Penny just got up. Our clinic dog just got up and she's kind of shaking it out. So we are all done for today. Are there any questions? Well, make sure you follow us on social. We've got some things coming up in the future. We're doing plantar fasciitis management and treatment at BP Runco. That's at their Crown Hill location. Doing that on the 9th of August. We've got overtraining series that we've basically done 3 courses for that, and we've got 2 more courses we're going through. And then we're also going to continue the bottom up strength series and focus on the hips. So a lot of those webinars are reposted online. If you go to our website, you can rewatch webinars on strengthening of the foot, webinars on strengthening of the ankle. You should be able to eventually watch this one, strengthening of the knee. And then we've also got the overtraining series where we've got the first 3 courses up for that as well, where you can learn about overtraining, load management, things like energy deficiency, as well as bone stress injuries. Those are all up online, and then we've got 2 more on the docket. So make sure for upcoming events to check out our events page, and then for past events, we've got a page labeled as courses that you can log into and watch webinars there. Alrighty, thanks for your time.